Hello and welcome to Healing Spaces, design dialogue for mental health, where we discuss the latest topics in behavioral and mental health design with industry experts and thought leaders. I am your host, Michelle Blackie, Head of Strategic Marketing at Pineapple. Mental health environments are often designed with the best intentions, but the real test comes after opening day, when people, pressure, and unpredictability enter the space. Today's conversation is about what actually works in the real world. I'm joined by Stacey Johnson, Hospital President and Vice President at Riverside Mental Health and Recovery Center in Virginia. And we will be exploring how design, operations, and community intersect in mental health care and what designers can learn from lived experience. Stacey, welcome. Now, before we dive into design, can I ask you to just set the scene? Can you give us a description of Riverside Mental Health and Recovery Center and the community that it serves, and what makes it unique?
Yeah, absolutely. And thanks for having me. It's great to be here. So Riverside overall is stationed in southeastern Virginia. We have a total of 5 hospitals on the acute care side. And then we have, of course, Riverside Mental Health and Recovery Center as a specialty hospital. We've got about 700 outpatient providers and a number of different outpatient clinics, and several other specialty care topics such as lifelong health and a rehab hospital. So we at Riverside Mental Health and Recovery Center have a goal of serving not only the Riverside community, but also our standard community at large. So we are located in Hampton, Virginia, where we see the majority of our patients from the Hampton and Newport News areas. However, we have patients from all throughout this state. At RMHRC, so Riverside Mental Health and Recovery Center, we treat ages 5 and up. We have a psychiatric emergency department that treats ages 5 and up. Then on the inpatient side, we have a total of 4 different programs. The first one is our adolescent acute unit, where we treat ages 12 to 18. We have then 3 different inpatient adult units, which are a mix of individuals that are involuntarily admitted, oftentimes with those with psychosis and or a danger to themselves or others. We also do an inpatient detox program. And then on the outpatient side, we have the full continuum of care for adults. So standard outpatient, such as med visits, therapy, individual therapy. And then we have our PHP program, which is a partial hospitalization program. So with that, we have 3 separate tracks, one for primary substance use disorders, one for mental health, and then one that focuses on the unhoused community, since that is an opportunity that we're working on in partnership with our community to really help treat those folks. Then we mimic all of those in an IOP, which is intensive outpatient. So the intent is, if you're in PHP, which is 6 hours a day, 5 days a week, then as you begin to get better, you would step down into IOP, which is 3 hours a day, 4 times per week. Varies a little bit depending on the individual treatment plan, and then standard outpatient. So our goal is really to provide all the services that we can to ensure patients are treated at the lowest level of care, and doing that, like I said, within our community, and meeting the needs of our specific community.
Well, it sounds like your days are pretty full because so much of mental health design is always driven by guidelines and best practices and assumptions. But once the space is operational, reality tends to take over, doesn't it? And so in that busy milieu, in the mix of what you were telling me, I picked up on something that really interests me, and that is the involuntary population that comes along. Because often when people are talking about designing spaces and making the spaces more home-like and increasing the dignity of the spaces, it is almost aimed at people who are voluntarily there. But how do you balance that with people who are involuntarily there and making those spaces accommodating and the best space they can be for all the different populations? How on earth do you balance that?
Carefully.
Yeah.
So that is always a challenge, certainly. So, yes, some individuals are more eager to receive our services than
Mm,
others.
mm,
And over the last 5.5 years, we've essentially restructured our whole hospital. So it was really an environmental rebuild. It was adding our outpatient clinic, adding the ED with the intent to serve our community that does have a high prevalence of serious mental illness, such as those psychotic disorders.
yeah.
So we were able to work really closely with our design company, and I'm not quite sure how they took all of these ideas that we spattered all over the walls and made something so beautiful and functional. So it's really amazing. But there was a couple things that really stood out to us as really specific needs. So the first thing that we really noticed is the patients that we're treating are getting sicker, voluntary or involuntary,
Interesting.
and often did not do well with roommates. So historically, I think you would find in most behavioral health treatment facilities is semi-private rooms, so at least two
Mm,
patients per room. So we quickly learned that we needed semi-private rooms, but we also needed private rooms. So we were able to then separate some of our units so that they were smaller. De-escalating milieu is really important. Our largest unit, a handful of years ago, was 38 beds, and it focused on the psychotic population, which is incredibly stimulating, as you can imagine.
yeah.
So our goal was to take that population that needed the most intensive level of care and provide smaller units where they could also have a private room if needed to help de-escalate. Another real specific design feature that we wanted for that population was a space where we could help educate our patients on de-escalation techniques, where we could provide an environment where they could begin some of that self-regulation on their own. So one of the big asks of us was a sensory room on each unit, and that's really a calming space that patients use individually. um, Early in their treatment, they might have a therapist help them, an art or rec therapist, and go through the processes. We use Sky Factory TVs in there with different images. Frankly, it's quite relaxing for all of us. And after we put them in, the team members were like, "Oh gosh, we all want one of these on our in our offices," and it's gorgeous. And we've built those to look like windows. And we also use fans for the physical sensory stimulation, and then some quiet noises as well. So those were real important things we've asked for to really be able to create an environment where both voluntary and involuntary patients would be able to cohabitate. Group rooms were really important to us as well, as that is a key feature in any inpatient treatment. And then we had this crazy idea for a psychiatric emergency department with a ton of flexibility, and knowing that a number of our patients were going to arrive involuntarily. In Virginia, we call it an ECO, an emergency custody order. So that's when police bring somebody into a facility and that are required to have an assessment to see if they need inpatient
Mm,
services, et cetera. So really having a environment that was physically safe, such as the ED, was really important to us. And that, again, is a mix of private rooms, but in that space, we also have an open treatment area, or more of an empath model there, because you certainly don't want to have a geriatric depressed patient in a room by themselves with the door closed. But also, you don't want to have a 25-year-old, very psychotic, loud patient in a community environment. So really
yeah.
being able to create spaces that treat all of our populations, so that we can separate folks if necessary, but it really also aids in the help from a milieu management perspective for the team.
Exactly.
So
I mean, it sounds like what on earth would you do without the flexibility? What are the designs that you use to create that all important flexibility? Because otherwise you'd have to have an individual space for everything, which is not possible. No one can
yeah.
afford that.
No, and I apologize. I know that was an incredibly long answer, but I think
No,
it just
no,
highlights some of the important areas. So, we thought about
absolutely.
the ability to, should we do private rooms for everyone? Should,
Mm,
that be our model? But again, you don't want to have a depressed, isolative person in a room by themselves. So creating that flexibility was very important. It also helps from a staffing line of sight standpoint, all of those things that are really important in this world that we live in over here, to create that. So,
mm.
but yes, without flexibility, we would be very limited to not only the number, but the types of patients that we're able to treat.
That is really impressive, I have to say, to just be able to balance those, just even those two extremes would be quite the juggling act, I think. So, in your opinion, what design choices would you say absolutely help reduce stigma and fear of the people arriving there? Is there anything in particular, or is it really just a general atmosphere that you try to create with a lot of input from lots of different things, from the design to the people to the layout to the materials, etc.?
So there's a couple things. So I think that in terms of reducing stigma, we've been able to really embrace different partnerships in our community, the school system, parent groups, really normalizing mental health. So I remember when I started here about 7 years ago, someone said, "What is your dream?" And my dream would be that people talk about mental health as much as they do their physical health, because
Absolutely.
we all experience mental health. We have our good days, our bad days, and some folks have diagnoses that impact their everyday life, and that's okay. So a lot of that we've really embraced from a community education standpoint, a team member education standpoint. I think COVID was an awful thing, but it also forced people to start to look at mental health a
Yeah,
little bit differently.
absolutely. Or
So
just even to start looking properly at mental
a-
health and not dismissing it.
absolutely,
Mm,
absolutely, it was such an isolative time that folks didn't know what to do, and children are so social, and they were
yeah.
all at home doing online learning. It really created a lot of challenges. And then furthermore, when folks had to get back to the real world, we saw a lot of things like an increase in need for detox when people couldn't work from home every day, or social anxiety with younger children who had not been in a public
Mm,
school. So
mm,
there was so many things that I think impacted destigmatization. What we've done here is really tried to create a home environment, a comfortable environment. And I think you and I may have spoken about this when we were designing the pediatric side of our emergency department. A lot of the design trends are the bright colors and
hmm.
the things on the walls, stuff to play with. I mean, I think even I remember going to the doctors as a kid and those little blocks that are all different
Oh,
colors.
yes.
And
Yeah.
right, that is really the standard, and it's excellent. And one thing that we were really deliberate about was to try to make our environment as comfortable and home-like as possible. And that has we struggled with that, but it has paid off
Yeah. Yeah.
consistently. Our families that come with their pediatric patients always say, "Oh gosh, this is just like a living room." And that's what we want. We
I mean,
want to
isn't that
create,
just the highest form of praise to for
oh,
someone to come to your institutional facility, which it can't get away from, but to say,
correct.
you know what, this feels like home. I mean, that is the point, isn't
That is
it?
absolutely the point. And that creates an environment where people are comfortable talking.
Yeah.
Right? The
Yeah.
parents are comfortable saying this is what's going on at home, and the child very similarly. So that I think drove a lot of decisions that we made in terms of the environment. I think comfortable seating is also so important too. You don't
Yes.
want to have someone on a brick
Exactly.
concrete chair, but a
Exactly.
comfortable recliner.
Because also taking into consideration the fact that people coming there are not coming there in the best circumstances of their
Yeah,
life. You know, they're not
correct.
coming for celebratory reasons.
Yeah.
They're coming when they need that TLC. And if that means some soft seating,
Yeah.
and a kind ear, then let's give it to them. Why not? You know, if this
Absolutely.
was a family member of yours, of course you would be doing that. So why shouldn't other people get that?
Correct. Absolutely. It's no different than if you were to go to a medical emergency
Mm,
department. We need to make it as comfortable as possible. So the patients that arrive here, particularly in our ED, they're having some of their worst days ever. So how
yeah.
can we make it just a little bit better? Um, Another thing is just making sure folks don't ever feel bad about their basic human needs or um, really food insecurities and things like that. So sometimes, the length that's offering a hot meal or a
Mm,
snack
mm.
can move a patient is really impressive. So I think things like that, just those are the little touches in an environment that can really help patients start their treatment on the right path.
It's so true though, because, we all know how interlinked the facilities are with the person's home life, or at the moment they're separated, but you can't separate a person from being inside a facility and their home. So you
Yeah,
can't give them a wonderful time in a facility and send them home to an awful home environment again and expect them to get better or to
absolutely.
improve. And I know from previous, full disclosure, previous discussions that we've had, I know that you are incredibly enmeshed in the local community. And I wanted to also just know how that has impacted what you did in terms of design with the structural layout, etc., or how you thought about things. Were there any particular main reasons that you wanted to do things a certain way based on the particular community that you have?
Sure, sure. There's several things that stand out quite quickly that help us with this. So I think the first thing was the location of our emergency department, really having it accessible, creating a treatment home. Oftentimes, like the acute care world, we are on a bus route for individuals that don't have their own transportation. So there were things like that
Yeah.
just drove where we were going to create the emergency department. But then looking at the community that we treat, oftentimes we have a number of individuals that are unhoused. And you heard me mention that with our
Mm.
outpatient services, creating a track specifically for those folks were really important. We also have a number of individuals who have a lot of food insecurities, and we were seeing that in our outpatient services. And that can be really degrading to an individual. So, creating an
Absolutely.
environment where we are able to stock enough goods for those folks, whether it be food or sometimes it's a sweatsuit. One of
Mm.
the we have an amazing foundation at Riverside who really works to find donations and such, and these are things that we're able to then provide to our patients because they left in paper scrubs and that's all they had, and that's
Yeah.
not the way that should be. So providing a sweatsuit to a patient can go a really long way. So if I were to pick a couple things in particular from a design standpoint that really stands out, if we were going to talk about food insecurities specifically, when we were building our space, we were like, oh, wow, our nourishment area is really big. And then when we looked at the percentage of our population with food insecurities and the length of stay in an emergency department and all of these things, we said, oh, wow, actually, it needs to be just a hair bigger for the
Mm.
storage necessary to be able to treat all those patients each day. So that's one thing that if I think of my prior life or where I've been in years past, that might not be something that was such a priority, but for
Yeah.
our community, it is.
Yeah. It's amazing what, being sent home with a meal or two in your
Absolutely.
bag can do in
Absolutely.
terms of changing your life or even changing the transition back to
Yeah.
home.
Yeah. For
So,
sure. We had a secondary design item that was really important to us, and that was how we are receiving our patients. So we
mm,
have a front entrance of our emergency department, and security for the team is really important. I for anyone in healthcare right now, and I think that's going to be even more true as we continue. So, but having a walk-in entrance that is secure, that we can ensure team member and patient safety was really important. So use of weapons detection and metal detection, that's one thing that was important to us. But secondarily, for individuals that are arriving in an involuntary capacity, having a
Mm,
secure entrance point was really important. I think a lot of times in mental health treatment, you'll find the driveway where the patients are then walked in. We are amongst two different residential communities, one on each side, and privacy is so important. So we were able
so
to
true.
create a Sally Port entrance where the ambulance or police car can drive right in. We're able to close the door and then secure the patient in a way that they need to be, so they aren't able to run if that was something that they were considering, but also get them in the building safely without concern for people watching or seeing.
Mm.
So we have our Sallyport entrance for folks that are arriving, as mentioned, with ambulance or police. And then we have our model that allows us to check them before they are in our treatment area. So get the initial triage done, perhaps change into paper scrubs, and do it with a lot of dignity and respect so that others don't witness that, and a lot of privacy. So those are two things that really stand out in terms of this area and the population that we treat.
So, one thing I want to pick up on that you mentioned, which was security, it leads me to another group of people at your facility, which is the staff.
Yes.
And what design choices do you feel best support staff during high acuity situations, for example? Or is there anything in particular that you did with your facility to make their lives easier and better? Because they do a very, a very difficult day-to-day job, which is often, it's hard and it's thankless, but it's so valuable. And we don't want to overlook them in terms of everything being focused on the patients, because the staff also need care and attention.
They do. And without them, we couldn't do any of
Yeah.
this work.
Yeah.
I'm glad we're taking a couple minutes to focus on them. So when I think back to the build and development of the emergency department, initially the goal was to have as much open as possible. And again, this is pre-COVID, so
Mm.
population was slightly different at that point in time, a bit less acuity and a bit less aggressive. So as we were working through this, and as folks are aware, these take several years to build from
Exactly.
design to move in. So we had our care team station where the whole team works. That's our therapists, our providers, MD, APP, our nurses, and our techs all work out of one space to have open communication. So the intent was to have that open to the pediatric side as well as the adult side of our environment. But as we got closer to opening, we saw on our inpatient side that the patients were becoming a bit more aggressive. They were making threats to team members. So keeping those individuals safe was really, really important. So we made a decision to put, it's called Lexan, almost like a plexiglass wall, and it's a half wall so that the patients can see the team and the team can see the patients quite openly. So that was a real critical feature in keeping our team safe. The other is the use of different communication devices, and those second as a panic button. We Any area that a team member might be alone with a patient, we do have cameras so that folks can see into those
Mm.
areas. It's not where patients might change or anything, but such as our screening room when somebody comes in most acute. We also staff our emergency department with protection officers 24/7. So two dedicated to the ED 24/7. And they have all the same training as our psych techs. So
Oh,
everything
wow.
from
Mm.
de-escalation, worst case scenario is there might be a need for manual hold, etc. So they go through all of that same training. So a lot of that's really important, as well as
Mm.
use of different patient monitoring devices. So from the employee standpoint, their safety is utmost priority.
Yeah.
And other things like ensuring their break room is right off the unit. So I've worked in plenty of places where you might leave the care team station or the nurse station and go next door to the break room, and you still hear and see everything that's going on. And that creates no opportunity for the team to actually
Mm.
take a deep breath. So in this case, it's actually right at the end of the unit. It's not far at all, but does create a division for team members
Which
to
is
be able to
important.
take a
Yeah,
deep breath.
absolutely.
Absolutely. Absolutely. So these are a couple of the highlights that stand out.
Yeah. But so what, if speaking more generally, what environmental factors do you find help reduce agitation or
Mhm.
help de-escalation? Because I'm sure you've been around the block enough times now to have a good feel for what works and what just doesn't.
Sure, sure, sure. So I think the use of colors and calming colors and things like
Mm.
that always is a highlight. In terms of environment, and to kind of go back to what we were talking about before from a flexibility standpoint, I do think that's really important. And that's one of the things that you can do to help keep your
Yeah.
environment calm and safe. So we utilize an SBIRT model. So if you come in our ambulance bay, if you walk in our front door, an SBIRT is screening, brief intervention, referral, and treatment. So if you were to walk in our front door and we do our initial screening and we say, oh gosh, wow, Michelle's hanging from the chandeliers and she's incredibly loud, and we know that that's going to have a big impact to our community. So
Mm.
we have at least an initial decision on where you might go before you even hit our treatment area. So I think having these spaces is really, really important. And then if you were to come in the ambulance bay, we actually have additional spaces very close to that, again, prior to our open treatment area, that might be a great stop point to take a deep breath, make sure that you are safe before we enter those areas. So really creating the environment to the clinical process was important so that we can treat all the various levels of care. So we have a room towards the ambulance bay where we might say, okay, you're going to be in this space for a period of time. We're going to work through all your initial screenings, etc. And by then you may have received some medication and now are a little more open to conversation and perhaps a bit less verbal or whatever might be
Yeah.
going on, no
Yeah.
threats of physical violence and things like that, then we know we can bring you into our treatment area. So having the flexibility and spaces available to be able to treat folks individually and as a group was really important.
I mean, it's like having little fire breaks, isn't it? To just make
Yeah.
sure that the process remains safe
Yeah.
all the way and there's no surprises really.
It's
But I,
similar. We
yeah.
create this in medical facilities. There's a special room where you might get a cast, another one where you're going to get your X-ray. And I think oftentimes we have not been able to create that on the behavioral health
Yeah.
side. It's like, okay, how do we retrofit this space to meet our needs versus
Yeah.
how do we build a space that is true to our clinical flow and the unique needs of our community? So I think being able to go from that perspective really allowed us a lot more flexibility than we would have had if we had a square box that we were.
Exactly. Or
Was our
retrofitting a
yes,
medical, behavioral health onto a medical situation is often
correct.
what's happened in the past, isn't it? But it's not
It's very
ideal.
common.
Not ideal, yeah. Yeah. How difficult was it in terms of working with the funding or trying to get the planning through? Was it easy enough, or was it a lot of having to justify what you want to do to get things the way you wanted them to do? How difficult is that side of it?
So, oh gosh, my brain's going to a million different places. So I'm
Or
just
does it
leaving
obviously
myself
depend on
a
a thousand things?
right. So to start, Riverside, like I would say 99% of hospital and health systems in
Mm,
the country, have a really long length of stay for psychiatric patients within medical EDs. So one of the first things I was tasked with when arriving at Riverside was to help reduce psych boarding in
Yeah.
EDs. So we had our behavioral health facility was already here. It's changed a lot since then. We had 2 units, and it was just it's very different than it was then.
Mm.
And so understanding how to do that is really what led to the model. So when we took the cost to treat a psychiatric patient in one of our acute care facilities, and keep in mind then the cost to transport them to our facility, the length of time you're waiting for
Exactly.
a transport. If it's an aggressive patient and they're with law enforcement, you're waiting on a second officer. So we quickly realized that to go 7 miles, it was sometimes taking upwards of 6 hours.
Yeah.
So when we really dove into this from a cost perspective, understanding the cost to treat a patient here is certainly much lower than in a medical acute care facility that, like we talked about, retrofitted. We've got a
Mm.
flex space and all the things related to that. There was a financial benefit if we can have as many patients start at this facility versus the other facilities. So really looking at cost from a different perspective. I think what happens is they're like, okay, an organization might say, okay, we want to create this space, and they see it as additional cost versus the transfer and potentially reduction of cost if you provide that care at another facility. So
Exactly. I think it's sometimes just looking at things from a different angle or really doing the sums with a different perspective in mind, saying ultimately, yes, it is all the layout and the cost of doing this, but we will be saving per patient if we
absolutely.
do it right, which, you know, and
Yeah.
also
And
if we're not
behavioral
retrofitting.
I think one of the behavioral health margins are really small.
Mm.
So to get
Mm.
to a place, and Riverside's a nonprofit, and we've committed to providing this care, but I think that's often the challenge in this
Exactly.
world is how do you make it make sense? And
Yeah.
and so this was how we got to the solution here. Um, but it will also say we are the first specialty emergency department in Virginia. We're still the only specialty emergency department in Virginia. So, as you can imagine, that came with its own set of challenges and legislative asks and all the things related to that. So, but to get back to your initial question regarding funding, we built our pro forma, what made sense from a financial perspective for us. Riverside did make a significant investment in these services. We were able to obtain some grant funding from the
Mm.
Department of Behavioral Health for our detox services, and then ARPA funds from the localities, and those are dedicated to some of our additional programs, not only the Psych ED, but really working with your community. And if your community is able to see that you're helping, then I think that there's opportunities there. So we were able to get some funding for that, but largely in part due to Riverside and where we started from a financial perspective for this. And then again, COVID happened. Of course, costs increased
Mm.
dramatically.
Mm.
So that was something that we at the end of the day said this is the right thing to do for our community, for our patients, and our organization overall. So that is kind of the process that we went through, and largely in part just due to Riverside's commitment to this population, which was amazing and something many people in my seat pray for every
Yeah.
day.
Exactly, with tears in their eyes. So
Yes.
then what does success look like to you when a space truly works? Or can you not really nail it down that easily?
Well, I think so one of the things that was really important to us was initiating psychiatric care quicker.
Mm.
So, if you arrived at one of our medical facilities, you perhaps weren't seen as quickly by a behavioral health specialist. Oftentimes, they're in medical facilities, there isn't therapists, there isn't folks sitting there to help de-escalate a patient and potentially avoid hospitalization. So while this sounds counterintuitive, our goal was always to reduce inpatient admissions and then start care quicker. So those were some of our initial measurements, which we've been successfully able to do. Additionally, help reduce the psychiatric boarding. So even if somebody's not able to be treated on our inpatient side because they're on oxygen or something like that, we are still able to get that patient to our ED, where they then see a psychiatrist each shift, a therapist. They work with their techs and things like that. So generally speaking, from a systematic standpoint, it's reducing the number of hours that psychiatric patients are in medical EDs not getting treatment. But success overall, from a patient standpoint, it means they're getting better. So
Yeah, yeah.
and we measure that several different ways through readmission rates, ED visits, treating at lower levels of care and success in some of our day treatment, our PHP programs and things like that. But success is really providing great care and
Mm.
helping people be successful in the community again.
So then on the flip side, is there a design flaw or a design mistake that you see repeated in your environment? Now you've been out in the field long enough and you've spent enough time in various facilities. Is there anything that you pick up on that you think, oh, I wish we could fix this?
In our space specifically, there's a couple things that I would have done differently.
Hmm.
For example, in our initial drawings, we had a direct access from back of house essentially to our care team station. There was concerns that our medication room wasn't large enough. So we removed that. If I had a do-over, I absolutely would have
Hmm.
kept that space,
Yeah.
that walk through. So I think that's one thing that's highlighted. Now, the way our space is configured, if there's an aggressive patient on the adult side, certainly you can access from the pediatric side, and those spaces don't touch. So there is a workaround there,
Mm.
but not always the most ideal, right? The other thing that I think is so variable that many organizations face is the fluctuations in pediatric populations. So, for example, oftentimes when school is not in session, August on inpatient psych units are very slow.
Really
Psych ED has really mimicked a lot of those same patterns. I can tell
interesting.
you the first or second day of school based on the number of pediatric ED visits that we have. It's that predictable. But what that does is creates this angst with how big your space needs to
Yeah.
be or how small it needs to be. So I think that that's something that all organizations are going to need to continue to work through. And again, in terms of flexibility, we do have rooms that can be flipped from the adult side to the pediatric side so that we can increase that. There was a time very early on when we said, okay, our adult volume's slower, but our peds are going through the roof. Do we switch? And
Mhm.
because our pediatric side is much smaller, do we switch and start treating the peds on the adult side until we can kind of work through all these patients?
Yeah.
So really having some creativity around that is really important. So the only other thing I think that I really want to highlight is outdoor spaces. So I
Mm.
started my career as a social worker. I am a firm believer in really getting your body moving, getting your serotonin levels up, and all of that. So being able to have outdoor spaces, which we've got dedicated spaces in our ED that are safe so patients can step outside and take a deep breath, and then on each of our inpatient units as well. And we also have a gym. So, you can be having the
Yeah.
worst day ever, but, playing a couple rounds of basketball or foosball or whatever else they might be playing that day, or kickball. I've never met an adult who doesn't want to at least try to play kickball.
Yeah.
Uh, and getting your body moving again really has such therapeutic value. So, highlighting those spaces is just super important as well.
It's so
So
true. Often, distraction is such a good medicine.
Yeah.
just distracting you from yourself, even if it is just kicking a ball around, going
Yep.
outside. It works like a dream
Yeah.
sometimes. So then I think my final question for you is, on ending on a positive note and looking a bit further afield, what gives you hope about the future of community-based mental health care?
Well, I think one promising thing is more companies are doing it and they're open to it, and that's amazing. Behavioral health has not necessarily been a competitive field where organizations might be fighting to get a cardiac patient or a
Yeah.
knee replacement. In this area, it's kind of been like, oh, well, who's going to take one for the team? And I think that's shifted. I think people are now saying, okay, psychiatric patients, substance use patients, they are everywhere in our organization. So what are we going to do to help them? And so that just warms my heart and creates a lot of promise. And of course, the destigmatization and all of that. So overall, I would say that's a big highlight. And then I think the second is helping patients through the continuum of care. I think what a lot of communities often have done as well is create an inpatient unit without having those services that help individuals stabilize within a community
Mm,
or their home or et cetera. So if you leave an inpatient psych facility and then you just follow up with somebody in 90 days, the likelihood of you staying stable for those 90 days is really low.
yeah.
So I think really creating the continuum of care on the mental health side is very promising. And it gives also our team the opportunity to see patients at their worst and sometimes at their best, which
Mm.
is really awesome and not as much of a revolving door. So I think overall the hope comes from the team that provides the care and the patients that are willing to receive it.
That's fantastic. I'm going to close on that lovely,
Okay.
hopeful, and positive note. And it brings us to the end of a very, very interesting conversation, which, as usual, is a stark reminder that design simply does not exist in a vacuum. And the most successful mental health environments aren't just compliant or practical, they work day in, day out for the people who rely on them. So, Stacey, thank you so much for sharing your extensive and honest insights from the front lines of community mental health care. And I'm sure this really will not be the last time that we'll be hearing from you in our podcast series. And to our listeners, if you enjoyed today's conversation, you can find our other episodes on Apple and Spotify, where we explore new ideas and emerging research in behavioral mental health design. Thank you for listening. Until next time.